Artificial joints, also known as prosthetic joints, have been developed to replace severely arthritic or traumatized ones. Prosthetic hips and knees were developed first and tested on dogs and monkeys. Artificial joints for several other areas soon followed. Made of high-quality stainless steel, titanium, and wear-resistant plastics, they are moderately expensive and are subject to numerous post-surgical complications, including infection, rejection, loosening, and material failure. Nevertheless, they have been very beneficial to many recipients, tremendously increasing the quality of their lives. The surgical procedures involved in their installation are complex and frequently performed by teams of orthopedic specialists that may do only one or a few types of joint replacement.
I'm Mike Shively, and this is Introduction to Anatomy and Physiology. Today we're going to talk about body movement and arthropathies, conditions involving joints. But before we begin, does anybody have a question from a previous session? Adam?
I actually have a question from a couple of previous sessions. When we talked last time about the anatomy of the joint capsule, the articular joint capsule, how does that tie in with the periosteum on a bone?
Good question. Let's go to an overhead camera here for just a second. We'll just pull up this skeleton of a lower inferior limb. We know that most of the surface of a bone is covered with a connective tissue proper called periosteum. When we get up near a joint, in this case a knee joint, that periosteum just blends into or becomes, by definition, the joint capsule. So periosteum and the fibrous part of a joint capsule are continuous with each other. Any other questions? All right, body movement. What can produce body movement? What kinds of things? There's only about 3 categories. Now, I'm not talking about being moved because you got smacked by a Pontiac and got knocked across the street. I'm talking about things within your own body that can cause it to move. What kind of things, Eva?
Muscle contraction.
All right, the first thing we ought to think of is muscle contraction. So we contract muscles. Those muscles, by getting shorter, pull on bones or cartilaginous structures and effect some movement. Where does the movement usually occur? At a joint. Okay. So we got muscle contraction, and we've got, here, I'm going to get some movement. I'm just going to let it go. I'm just going to let it go. What's happening?
Gravity.
Gravity. So gravity can also produce body movement. Muscle contraction, gravity. And there's another thing that we probably ought to mention. It's a very minor amount of the total movement that occurs in our body, but something that ought to be mentioned is elastic recoil. If we bend a body part further than it really wants to go, and then let it go, it'll flip back a certain amount. Overstretching something and then letting it go, it'll pop back. So we call that kind of thing elastic recoil. For example, I used to be able to bend over and touch the floor. Okay, now when I try, I get pretty close, but then as soon as I quit trying, I pop back up to about right here. You know, elastic recoil is springing me back. So I'm not contracting any muscles to come back, and it's certainly not gravity that's popping me into the more upright position, but it's elastic recoil. So let's take a look at a graphic that summarizes those 3 things that can produce body movement. First, we have contraction of muscles, we have gravity, and we have elastic recoil. And again, the first 2 are the most important to remember. All right. We're going to define body movement as locomotion, the word locomotion. So we're going to say body movement and locomotion are synonymous with each other. When we think of body movement with contraction of muscles, the muscles provide the force, joints provide the pivot points, and bones function as the lever arms because the muscles have to attach to bones and or cartilaginous structures in order to be able to pull on something when they contract. So just remember, we got bones, joints, and muscles interacting to form these lever systems that produce most body movement. Now, not all body movement is produced in that manner. If you purse your lips, or close your eye, there's no bones or joints involved in that process. We have a circular or ring-shaped chunk of skeletal muscle tissue that's involved in effecting that particular motion. But most body movements involve those three things that I just mentioned. Let's look at a graphic that summarizes those then, locomotion or body movement. So let's think of most locomotion as being produced by contraction of muscles and/or gravity. Muscles provide the force, or gravity can provide the force. Joints form the pivot points, places where the actual motion occurs, and the bones themselves, to which the muscles attach, then serve as the lever arms. What I want to spend some time today doing for the first part of our discussion is talking about some of the various kinds of locomotion, some of the words that are used to describe specific kinds of locomotion, and defining those particular kinds of movements. And the first term that I want to talk about is flexion. Let's go to the overhead camera and look at this word. Flexion. Who would like to define that as it applies to the skeletal system and joints in particular? Bryce?
Is it where, like, you can flex your elbow joint, or flex your superior limb at the elbow joint?
Well, you're
Reduces the
demonstrating
angle.
flexion at the elbow joint with the motion that you're producing there. Can we define in general what we mean by flexion in the musculoskeletal sense? Hazel?
Is it a decrease in the flexor angle?
Technically it is. It's actually not a very easy word to define. You have to be very careful with the words you choose. It's decrease of the flexor angle at a joint. Now that leads us to several questions. What do we mean by the flexor angle at a joint? Well, if we start out, we'll take a look at this skeleton for a moment. The skeleton is almost in the normal anatomic position. And the flexor angle is defined for each of the joints in the limbs. The flexor angle on the shoulder joint is the front angle. The back angle is the extensor angle. Flexor angle on the elbow joints, front side. The back one is the extensor angle. And for the flexor angle on all of these joints down in the hand is also on the front, or in this case, palmar aspect. So it is defined by definition on the superior limb. All the joints in the free part of the limb have what we call the flexor angle or the flexor surface on the front side of that particular joint. That means if we make that angle smaller, by definition, we are flexing that particular joint. So we're going to define flexion as body movement that makes the flexor angle of a particular joint smaller. Now on the shoulder joint, we said the flexor angle's on the front side. We have to imagine an imaginary coronal type plane coming up behind the shoulder joint. So if we get a protractor out and measure this angle in the normal anatomic position, it'd be about 180 degrees. So if I elevate my superior limb in this manner, such that I reduce that, say, to 90 degrees, I've flexed my shoulder joint, okay? If I go the other direction, we haven't defined extension, but I'm just here to tell you it's opposite of flexion on a particular joint. If we go the other direction, we have extended the shoulder joint. On the elbow joint, Bryce demonstrated flexion of the elbow joint. Extension of the elbow joint is the opposite motion. So flexion is making the flexor angle smaller. Extension makes the flexor angle larger, does it not? Down in the joints of the hand, on the carpal joint complex, flexion makes the flexor angle smaller. Extension makes that flexor angle larger. Okay, and then on the digital joints as well, and we'll define digital joint as any joint within the between phalanges, within the digits. And if we make those joints smaller, make the angles on the flexor angles on the joints smaller, we flexed them. So if we make a fist, basically, if we roll all our digits up into a fist type configuration, we're flexing the digital joints. Let's go to the graphic that defines flexion, and we'll take a look at that graphic. Flexion is movement of joint components such that the flexor angle of that joint gets smaller. Or we could define it as saying making the extensor angle larger, okay? And then if we take a look at the next graphic, extension is defined in a very similar manner. On this next graphic, we see that extension is movement of joint components such that the extensor angle gets smaller or the flexor angle gets larger. I'm here to tell you, if you're just starting out in this area, pick one of these ways to define flexion and extension and stick with it, because it gets a little bit confusing when you keep going back and forth, I think. Important thing to remember is that we have to define for each joint what the flexor angle is, where it is on that joint. And we've already mentioned that on the joints of the superior limb here, all the flexor angles are on the front and all the extensor angles are on the posterior sides of those joints. If we go down to the inferior limb, the flexor angle at a hip joint is on the front side. Down at the knee joint, down below, I don't think the camera can get that far down, but on the knee joint, the flexor angle is on the posterior aspect. So we've got a flexor angle on a hip joint in the front, like it was on all the joints in the superior limb. If we get down to the knee joint, I'll come out here in the front. If I pull my inferior limb up into this direction, what I've done here at the hip joint then is I've flexed the hip joint, because I made the flexor angle, which is on the front side, I made it smaller. In the normal anatomic position, it's about 180 degrees, about a straight line. And if I bring my thigh up in this manner, what I've done here at the hip joint is I've flexed it. I've also flexed my knee joint when I'm in this position, because the flexor angle on knee joint is on the posterior side. So if you make that angle smaller, you flex the knee joint. Okay? I want to go to overhead camera and take a look at this skeletal model. It doesn't move very much, but we can get a little bit of motion here. Down at the ankle joint complex, if you bring your toes toward your nose like this, you've flexed the ankle joint. If you put the metal to the pedal or push down on the accelerator pedal or brake pedal, you've extended the tarsal joint or ankle joint. Flexion of the ankle joint, extension of the ankle joint. Now in sports medicine, on this particular joint, they often will talk about this motion as being dorsiflexion and this motion as being plantar flexion. So in sports medicine, they have special language on the movement here at the ankle joint, dorsiflexion and plantar flexion. What I'm here to tell you is that what they call dorsiflexion is the same as anatomic flexion of that joint, and what they call plantar flexion is the same as extension of that joint. So the flexor angle is on the front or anterior aspect here in the ankle joint complex. If we go on down to the digital joints in the toes, the flexor angle is on the bottom or plantar aspect. So if you roll your toes up into a little foot fist, then what you've done is flex the digital joints down there. And if you pull your toes up in an extended manner, what you're doing is pulling your toenails up again toward your nose so that you can admire your beautiful pedicure or whatever. So on the inferior limb, it is a little bit confusing because the flexor angle pops back and forth. It's on the front on the hip joint, behind on the knee joint, on front on the ankle joint, and then it's on the underneath side in all the digital joints down within the foot. The extensor angle, obviously, is on the other side of that same joint. So if you know where the flexor angle is, you know the other side of that same joint is the extensor angle. Now, extension and flexion are primarily used in the free parts of the limbs. We don't use them in hardly any other part of the body except for the vertebral column as a whole. If we're talking about the vertebral column as a whole, if we roll ourselves up into a ball, assume the fetal position, or roll up into that kind of a position, bend over at the waist, that kind of movement, what we're doing is flexing the joints of the vertebral column. And if we stretch back, like we might in the morning when we first get out of bed, we're extending the joints of the vertebral column, because the flexor angle of all the vertebral joints here is considered to be the front side, and the extensor angle is the posterior aspect. Now, when you use flexion and extension, when you use these terms, it's best to always name a joint and not flex bones and not flex limbs per se, but flex a particular joint. Let's take a look at a couple of graphics that summarize what we just said here. In this first graphic, we can see the flexor angles of the various joints summarized. It's the anterior side of all joints of the superior limb and the anterior side of the joints of the vertebral column. It's also the anterior side in the hip and ankle joints. It's the posterior side of the knee joint, and it's the plantar or inferior side of all the digital joints of the foot. Now here's a term, digital joint, and we probably ought to define that. I blew through it just a second ago. Let's look at the next graphic, which defines digital joint. It's an unofficial term. That's the reason I've put it in quotes here, but it's very useful because what it does is indicates any joint in which phalanges are involved. So in a hand, the digital joints, if we can go to the overhead camera for just a second, we'll take a look at a hand. The digital joints of a hand would include these metacarpophalangeal joints, as well as all of the interphalangeal joints. Those are all umbrellaed by the term digital joint. Okay? The same way down in the foot, the digital joints of the foot would be the metatarsophalangeal joints, as well as the interphalangeal joints involved in that region. Any question about flexion and extension? Yeah, Bryce?
So can we just say flex the joints, or can we flex muscles as well?
That's a good question. We certainly talk about flexing our muscles. In reality, to avoid the confusion which otherwise might ensue, I'm going to encourage you to say contraction of a muscle might either flex or extend a joint. And that way we won't get the two confused. Kind of like the word spinal column. You know, are we talking about the spinal cord, or are we talking about the vertebral column? And so we probably would be best served by using flexion and extension in reference to joints. And when we're talking about a muscle getting shorter, use the word contraction.
Okay.
And then we won't get confused, I think. Let's see how you're doing on this. I'm going to do some motions here, and you tell me what I did to what joint, okay? Okay, if I take this particular joint and I go like this, what am I doing?
Flexing the carpal joint.
Flexing my carpal joint. I could say flexing my wrist joint, right? Or if I go the other direction, I'm extending that joint. Now, this is about the normal anatomic position on this joint. Of course, it's down here at the side, but it's about 180 degrees. We can actually, on our carpal joint, we can extend it considerably beyond the normal anatomic position, can we not? Sometimes we apply the term hyperextension to extending beyond the normal anatomic position. But there are two ways that hyperextension can be defined. We can also define hyperextension in the clinical sense by indicating that some motion has occurred which has injured this particular joint. We've extended this joint such that soft tissue structures, or perhaps even skeletal components, have been damaged. So we have to distinguish, and probably by the usage in which you find the term used, particular usage will indicate whether we're talking about simply moving it beyond the normal anatomic position in the extension direction, or whether we're talking about a traumatic incident which has damaged some of the components. All right, what am I doing right here to this joint? What is it? What's the joint? Flexing my elbow joint, okay? And now on this joint, if I go up this direction, what am I doing?
Flexing the shoulder
I'm
joint.
flexing my shoulder joint. And if I move this direction, I'm doing what to my shoulder joint? I'm extending my shoulder joint. Shoulder joint's another one of those joints that can be extended many degrees beyond the normal anatomic position. So I am anatomically hyperextending my shoulder joint. Okay? And if I do this at this joint, what am I doing?
Flexing the hip joint.
Flexing my hip joint. And I've already done something here at this joint. What have I done?
Flexing the knee
I've
joint.
flexed my knee joint. Now I'm going to try something. I don't know if I can do this without falling down or not. What am I doing now at my knee joint? I'm extending my knee joint. Okay? All right. Any questions? Starley.
What is it called then when you bring it out to the side?
We're coming to that. Another set of terms. Another set of terms are adduction and abduction. Let's go to a graphic that will define these terms for us. Abduction and adduction are side to side, if you will, motions that either involve whole limbs or digits or maybe just a hand or a foot. So let's look at the graphic one more time. And we're going to define abduction as moving a limb, hand, or digit away from a reference position. That's going to be the, quote, normal anatomic position generally. And adduction is moving any of those same body parts toward a particular reference position. Now, the reference position for limbs is going to be the mid-sagittal plane, starting in the normal anatomic position. So Starley asked, what do we call it when we do this kind of a motion out here like this? This would be called abduction of the superior limb at the shoulder joint. The reference is the mid-sagittal plane, and starting in the normal anatomic position, what I'm doing is I'm moving this limb away from the mid-sagittal plane. Even when I get clear up here and are actually coming back toward the plane, because I'm moving away from my original referenced position in the resting normal anatomic position, then that all this motion all the way up to here is still considered to be abduction of superior limb at the, in this case, shoulder joint. We can also have this side-to-side motion with digits. If we splay our digits away from each other in this manner, we are abducting the digits of the hand at the metacarpophalangeal joints. We can move a hand toward or away from the mid-sagittal plane. Okay? If we move it toward the mid-sagittal plane, that's adduction. Moving it away from the mid-sagittal plane is abduction. Now back here on the digits, we don't use the mid-sagittal plane for the reference on them. We actually use the axis of the limb, which is an imaginary or virtual line that simply runs lengthwise down the limb and through the middle of the third finger or middle finger here. So if we're moving the other digits away from the middle finger, as we would be if we spread our fingers apart, we would be abducting the digits of the hand at the metacarpophalangeal joints. And bringing them back toward the middle finger for the reference point, we are adducting the digits of the hand at the metacarpophalangeal joints. But for superior limb, the reference is median plane, and for hand as a whole, the reference is mid-sagittal plane. That makes sense to you? So the side-to-side motion, now we can, of course, do that same kind of thing in inferior limb. If I get out here in front where the camera can see me a bit, if I take an inferior limb and swing it out to the side like this, I'm abducting this inferior limb at the hip joint, okay? Abducting it at the hip joint. Bringing it back toward the median plane would be adducting it. Let's take a look at a way we might be able to remember the difference in those terms, because they're a little confusing. Let's go to the overhead camera. If we remember that AB, the prefix, means from or away from, and that AD, the prefix, means to or maybe toward, maybe it'll help us with those terms, because the rest of the term is spelled the same, abduction or adduction. Sometimes in the anatomy lab, when we're talking across the room and people can't hear all that well anyway, people will say abduction versus adduction to clarify whether they're talking about abduction or adduction. Now, another thing I want to clarify for you too is when these terms are used, we don't adduct or abduct joints. We adduct or abduct limbs, hands, digits at certain joints, okay? So when we talked about extension and flexion a bit ago, we always said when you use those terms, we really ought to name a joint that's being extended or flexed. So we're going to flex the carpal joint, or we're going to extend the shoulder joint. When we use adduction and abduction, we're best served by saying adduction or abduction of such and such a body part at such and such a joint. That's just a way that makes it absolutely clear to the listeners what is trying to be conveyed. Any questions about that? Now we can do the same thing. You know, we talked about abduction and adduction of the digits here of the hand at the metacarpophalangeal joints. Do that same thing down in feet with toes. You spread your toes apart, abduct the digits of the foot at the metatarsophalangeal joints, or bring them back together. Eva?
You said the reference point for adducting and abducting the digits was the middle finger?
Middle finger in a hand. Now, for some strange reason, when you go down to a foot, the reference there is an axial line that passes down through the second toe.
Okay.
I have no idea why they decided that, but that's the reference.
Would that mean that you cannot abduct or adduct the middle finger itself?
Technically, it means that you can, although you can certainly wiggle it back and forth a little bit with, you know, between the other two. Mm-hmm. But technically, the axis of the limb runs right down through it in a hand, and that is what we're going to reference to either bringing these other digits toward or away from.
Okay.
So, any other questions? In addition to extension and flexion, adduction and abduction, there are some other terms. Rotation, I am rotating antebrachium and hand right here. It's a spinning of an elongated part about the long axis of that part, okay? So I'm rotating my antebrachium, and then my hand simply follows that because it's attached to the end of it. That we can do some rotation clear up here at the shoulder joint. Most of this that I'm doing right now, my shoulder's not involved. Most of it's occurring down at the elbow joint, to be honest with you. So I'm getting a lot of rotatory movement between the radius and ulna up at the elbow joint complex. And then because the hand is actually attached, you know, skeletally down to the distal end of the radius and ulna here, then the hand is actually where we see most of the motion occurring. Adam?
Does it matter which direction you're rotating in?
Either direction, although we have specific names for rotation in a certain direction, as you might imagine physiologists would have. If we rotate such that the palmar aspect of the hand comes around to the medial aspect and then superiorly, in this manner, rotating in this direction, that particular kind of rotation is called supination. Let me put that word up. While we're on this overhead camera, I'll demonstrate supination again. It's a rotatory movement that would move the palm medially and then up in this manner. Some of the anatomy students remember this to like eating soup with your hands, supination, this kind of rotation. Now the opposite rotation, rotating around the opposite direction, is called pronation. Let me put that word up here as well. So there are the two terms that describe rotation in opposite directions on a hand, supination and pronation. Again, supination bringing the palmar aspect forward to the front or up, and then pronation rotating in the opposite direction. So when we stand in the normal anatomic position, the palmar aspect of the hands they're supinated, okay? So in the normal anatomic position, if we stand here, I don't know if the camera can get down low enough. hunch up a little bit like this. We can see that the palms are in the supinated position. Rotating those in the opposite direction like this is called pronation. Supination, pronation. Okay? Now, can you do that same kind of motion down on a foot?
Yes.
Kind of. It's a little bit modified because at the ankle joint, the foot folds under or bends about 90 degrees. You know, if we stand in the normal anatomic position with the wrist here, we've got a straight line going down, kind of a planar aspect of the limb here. There's no bend at the wrist. But in the normal anatomic position, there's quite a bit of a bend down at the ankle. If you rotate a foot in a manner that's, say you wanted to look, see if you had something stuck on the bottom of your shoe. Typically, you roll the inside of the foot up to the inside and then up, and I know the camera can't catch this, but you know what I'm talking about when you're taking a look and see if you got some chewing gum. You know, it feels like getting stuck when you're walking down the hall here, and you think you got something on the bottom of your shoe. That kind of rotation toward the median plane, and you can't do it nearly as far as you can with a hand, but that same kind of thing is called inversion of a foot. Inversion. Let me write that word up for everybody to see. So we'll go to the overhead camera. And then the opposite motion of a foot, where you'd say put the plantar aspect of the foot back down on the ground surface, that's called eversion. So inversion of a foot really corresponds to supination of a hand, and eversion of a foot corresponds to pronation of a hand. And those are the two places that we have kind of special case rotation type movements. Yeah, Bryce?
Do they have a name for the rotation of your leg? Like you can take your leg and you can put your toes all the way out to the side and then roll it back?
Actually, that's, yeah, if you're standing here and you, in the, say, normal anatomic position, and you move your inferior limb such that I'd be pointing my toes straight over here to the right, for example. I think they have a name for this position in ballet. I never took it myself, but my daughter did. We're actually rotating at the hip joint. And sometimes rotating this direction, we'll call that external or lateral rotation. If we bring the foot back around toward the front, we'd call that medial or internal rotation. But the rotatory movement's actually occurring at the hip joint. Just like we can rotate clear up here at the shoulder joint. You know, we talked about that a little bit. But the kind of rotation that we're talking about here is not involving the shoulder joint at all. It's basically all occurring at the elbow joint.
Okay.
See, there are a couple of other special case kinds of movements that we need to talk about. Protraction is a word that was invented by kinesiologists to kind of describe a movement that involves taking a body part forward. If we do a stiff arm in football, okay, I'm moving several different joints. And so I could describe the actual motion at several different joints, or I could say, I protracted my superior limb. I moved my superior limb forward. And the opposite, pulling that body part back, is called retraction. And you can imagine there's several things you can do this kind of movement with. You can do it with limbs. You can do it with your jaw. You know, if you want to pout, you can stick your little chin out and protract it, or you can pull it back in and retract it. So let's look at graphics that define those. Simply, protraction is simply moving a body part anteriorly to the front, and retraction is moving a body part, next graphic, is moving a body part posteriorly. Okay? Any questions about protraction or retraction? Now you can do the same kind of thing out here to the side. Just like, you know, it gets very complex when you got several joints involved. I can get over here to the side and I can do this kind of a motion. I'm still flexing and extending my elbow joint, even though this motion is not really occurring in sagittal type plane like we usually think of flexion, extension type movements to be occurring in. But that's simply because I rotated externally or laterally here at the shoulder joint, and then down the elbow joint, I'm still doing the same old flexion and extension that I would have been doing had I been around here in the closer to the normal anatomic position. So all of those kinds of things can add a lot of complexity to the study of joint motions, as you well might imagine. Starling?
How does the head work? Like, are you actually flexing it ever or
Okay,
extending it?
yeah, when we dip our chin down low, or like maybe in the reading position if we're going to read something that's down in front of us, we're actually flexing the joints of the cervical part of the vertebral column, okay? Remember we talked about the flexor angle being on the front side. If we say, no, I didn't read that chapter like I was supposed to before I came to class today, what we're doing is rotating to the left or the right joints of the vertebral column. Again, primarily in the cervical region. So this is rotation, this kind of thing. Flexion, extension, left rotation, right rotation. Now, what do we call this kind of a motion like, gosh, I don't know? Well, a lot of times, physiologists will call that lateral flexion of the joints of the cervical part of the vertebral column. Like if you're, taking your head to one side or the other rather than twisting it. Any other questions? When bones suffer severe traumatic injury, they're often broken or fractured. When joints suffer severe traumatic injury, we say that joint is dislocated or luxated. Let's take a look at that word in a graphic. Luxation is a dislocation of a joint such that the skeletal components are no longer in correct position. Now, if we go to the overhead for just a moment, the term subluxation implies a partial luxation or a partial dislocation. And the term, again, luxation itself implies a complete dislocation. Well, what do we mean by a partial dislocation or luxation versus a complete dislocation or luxation? Let's go back to this overhead screen and take a look at, let's take a look at the knee joint, and we'll kind of schematically represent the components here and see if we can make sense of what we're trying to say. Let's take a look at the distal end of a femur bone. We'll put a patella right there. Say this is a tibia. And we'll put a little fibula in here. And we'll say this is the way things are supposed to line up. The two femoral condyles here are supposed to be more or less centered over the two tibial condyles. And everything's lined up axially, just the way things are supposed to be. But after we get done skiing or skateboarding, perhaps, we might be in a situation where, I'll draw a little bit smaller, just because I'm running out of room here a little bit, but we'll have a situation where perhaps this is the way things are lining up, with the tibia kind of over here to this side. Here's the fibula. So it's not lined up the way it's supposed to be, but we still have a little bit of articulation between this particular condyle of the femur bone and the tibia. This would be called a partial luxation or a subluxation. On the other hand, we'll go over here and say if we have a more severe case, and this is the distal end of the femur bone, and the tibia is clear over here someplace, maybe not quite in the next county, but certainly not where it's supposed to be. Then this situation, where there's no contact at all between articular surfaces of femur bone and tibia, this would be then a luxation. So from a medical standpoint, we're going to differentiate subluxation and luxation simply as, is there still some contact between the articular surfaces, and if that's the case, we'll call it a subluxation, or is the dislocation so severe that the skeletal components aren't making any contact with each other whatsoever, at least their articular surfaces aren't making any contact whatsoever. If that's the case, then clinically it would be called a complete luxation or complete dislocation. Now, in the medical field, oftentimes physicians will put directional terms onto subluxations and luxations. They'll say a medial subluxation or luxation or of such and such a joint, a lateral luxation or subluxation of such and such a joint. What do they mean when they add a directional term? Anybody know? Starley?
It means that the bottom joint it means that it's going medial to the top. I thought it had something to do with top or bottom.
It does. It does. And as a matter of fact, in the limbs where most of these kinds of injuries occur, they use the directional term to describe where the distal skeletal component ended up relative to the proximal one. So if things are supposed to be lined up like this, and after the injury, if this distal part down here goes medial, we'd call that a medial luxation or subluxation. If it goes laterally relative to the proximal part, we'd call it a lateral subluxation or luxation. So the directional term, when you see it applied to a dislocation, always implies where the distal skeletal component ended up relative to the proximal skeletal component. Bryce?
So if it moves front or back, does that mean that it's an anterior or posterior?
Exactly.
subluxation?
If the distal skeletal component goes forward to where it's supposed to be, we call that an anterior luxation or subluxation, and if it goes posterior, we call it a posterior luxation or subluxation. Just remember, the directional term always goes with the distal skeletal component. Have you ever been sitting in a parked car waiting for somebody, and if you haven't had this experience, get married, it'll happen. You'll be waiting, and you're not paying too much attention. Maybe you're reading something, waiting, and the car next to you decides to back out of the parking place. And have you ever had that feeling for just a moment that your car was going forward? Have you ever actually hit the brake under those circumstances? You know, you're sitting there, you're not even running, you're in park, but you get the impression that all of a sudden your car's got a mind of its own and it's moving forward. What's actually happening, of course, is yours is not moving, the other's moving backwards, but the relative motion could be described as you moving forward or it moving backward. I mean, that we have that kind of relative thing happen. Obviously, if we're talking about the distal skeletal component going laterally or medially, then the proximal skeletal component is going to be going medially or laterally. You know, it's a relative thing. To avoid the confusion in the biomedical field, what they've done is simply said, hey, we're going to use the directional term to describe where the distal component is relative to the proximal one. So, Bryce?
And you talked about most injuries to the shoulder joint and how it's with the acromioclavicular joint. If they dislocate the shoulder joint, is that what it's referring to, or is it the humerus that usually comes out?
When they actually, you're not sure, to be honest with you, and when you see the newscast, you're not sure. Usually the severe injuries to shoulder joints in athletes are usually a acromioclavicular joint. The shoulder joint is an interesting joint. The true shoulder joint between here, the glenoid cavity, the scapula, and the head of the humerus, is actually an interesting joint in that when you're totally relaxed, or if you're under anesthesia, you can actually luxate it in just about any direction you want. It's a very, quote, loose joint. It does not have well-developed ligaments that stabilize the bones relative to one another. In fact, what nature depends on instead are several large muscles whose tendons cross over that joint. You've probably heard of the rotator cuff, which is a group of muscles whose tendinous portions cross over that shoulder joint and actually help hold the head of the humerus in proper configuration relative to the glenoid cavity of the scapula. So, Any other questions? Let's go back to this knee joint. From the front, this would be the femur bone, tibia. Put a little fibula on here so he doesn't feel left out, although he's not a major participant. He's kind of like Turtle in the Goldilocks and Three Bears, you know. Just kind of laying there on the side of the trail, didn't have a big part. All right, femoral condyles, tibial condyles. Now, there's a well-developed patellar ligament that comes down. I'm not going to draw it, but it comes from the patella down to the tibial tuberosity and reinforces this joint on the front side. Over here on the lateral aspect, in addition to the joint capsule and outside of the joint capsule, we have a real well-developed collateral ligament. Oftentimes, again, it's called the medial collateral ligament in the emergency room, although its official name is tibial collateral ligament. We've got the same kind of thing going on over here, but it goes all the way down to the fibula. So this one over here is called the fibular collateral ligament, sometimes called the lateral collateral ligament. And in addition to these and the patellar ligament, which we're not going to draw because it'd kind of be in our way here, there are two well-developed intracapsular ligaments. I believe we looked at these on an actual model last time, the anterior and posterior cruciate ligaments. And the anterior cruciate ligament comes down to the front of the tibial plateau, something like that. And the posterior cruciate ligament comes down to the back of the tibial plateau like that. The reason these are called cruciate ligaments, anterior and posterior cruciate ligaments, is if we'd view this thing from the side, I want to make one more little drawing here, and we'll pretend like we can see the whole ball of wax from the side view. Here's the tibia coming down, fibula sitting right here. But the anterior cruciate ligament, of course, it'd be a dotted line because it's in between the tibial condyles, but when it gets down here, it comes down to the front of the tibial plateau, and that's the reason it's called anterior cruciate ligament. And the other one kind of crosses it, and that's the reason they're called cruciate ligaments. Comes down here to the back. So this would be the posterior cruciate ligament. Now, if we have a certain kind of traumatic incident involving the knee joint, we can rupture one or both of these. If we rupture this anterior cruciate ligament, or actually break it in the manner like I've shown there by just erasing part of it, I hope you can see that that would allow this tibia and fibula that's attached to it to slide forward. And when that happens, we say that person has an anterior drawer sign. Now, the reason they called it a drawer sign, I don't know if the camera can catch me sitting here on the edge of the well, let me just show you. If I'm sitting on the edge of a desk and a physician is examining my knee joint possibly to see if I have this particular injury, a ruptured anterior cruciate ligament, he'll grab my crus or leg just below my knee and he'll pull forward. And if my anterior cruciate ligament is ruptured, then that whole segment of my limb will slip forward about ½ inch. And it'll pop back and forth, forward and back, forward and back. It doesn't hurt much when it does it. The original injury probably hurt, but it doesn't hurt much to slide it back and forth. And the reason that it'll slide forward is because that anterior cruciate ligament is ruptured. And when you have that particular injury, oftentimes one of the big collateral ligaments is also ruptured, and one of the menisci that we talked about in a previous session is also injured. So there's a lot of things that can happen when you have traumatic injuries of the knee joint. And those typically will require some kind of surgical intervention. There's several different surgeries for repairing cruciate ligaments, especially anterior cruciate ligaments, which is injured far more often than the posterior cruciate ligament. They will use some of the patellar ligament and relocate it. They'll use some fascia from the side of the thigh and sew that in place. There's even some artificial substances, some carbon fiber materials that have been actually implanted in the knee joint to replace a ruptured cruciate ligament. Let's go back to this overhead just for a second. Let's suppose that a middle linebacker slams into you. You're the fullback. Middle linebacker slams into the side of your knee joint in the manner that I'm indicating with my hand. So we got tremendous force being exerted in this direction right there on that joint. Now, obviously, things over here get bruised, and they won't feel very good. But hopefully, you can understand how that might cause this knee to buckle in this direction, and what's going to happen over here on this tibial collateral ligament. What will it do? It'll get stretched and torn, will it not? Because we'll bend the knee here to the side, inside, in an anatomically unacceptable way, such that things over here get bruised, things over here get stretched and ruptured. So these are some of the kinds of ways that knees can be injured. Any question? How many of you, anybody here have suffered anterior cruciate rupture or a meniscal injury? Bryce?
I was just wondering, I've heard of a lot of people tearing their ACL. Is that the anterior
Cruciate ligament? Yeah. Let's put that up here so people can see it. Again, we'll go back to the overhead for just a second. The acronym ACL stands for anterior cruciate ligament, and PCL stands for posterior cruciate ligament. Any other questions? Arthritis. We know that ology means study of. Itis means what? Eva?
Swelling?
Swelling is a factor in it, but that's not the definition. It's one of the signs. Yeah, Hazel?
Is it inflammation?
Inflammation of. Arthritis, in this case, would be inflammation of a joint. Arthritis. Let's put that word up on the overhead so everybody can see it in print. Arthritis. Inflammation of a joint. Now, there's a lot of different things that can inflame a joint. We can have traumatic arthritis. Sprained ankle is an example, traumatic arthritis. Hyperextension, clinical hyperextension of a joint. In other words, your wrist gets bent back too far, or a finger gets bent back too far in the extended type position here of those involved joints. Traumatic arthritis, okay? Infectious arthritis would be a condition where we actually had microorganisms that were growing within a joint. And usually that's going to come in association perhaps with some traumatic incident where joint components have been exposed to the outside world, although it can, in some instances, involve blood-borne bacterial infections as well. So that's what we mean by infectious arthritis. The implication is there's living organisms that are growing in that joint and causing difficulty. Degenerative arthritis is the name given to arthritis where joint components are breaking down. And that basically is, in most cases, an old age phenomenon. With some exceptions, joints are amazingly resilient structures in that you can use them and abuse them quite a bit with all your life with no, I mean, they basically don't wear out in most instances under normal circumstances, even those individuals that do the same kind of repetitive motion. Now, if you get into extreme situations where some joint components are continually being pushed at or past their limits, like a baseball catcher. Baseball catchers typically have problems in older age with their knees, okay? Because the squatted down position that they have to maintain for, a lot of hours each week playing their particular position pushes a lot of those joint components beyond their normal physiological limitations. Starley?
When you said it was a breaking down of the joint, what's breaking down within the joint?
When we start seeing inflammation of joint component, and it's not infectious, it's not traumatic, it's not cancerous, there's no gout involved, it's not rheumatoid arthritis, and this person's getting old. Classically, they call that primary degenerative joint disease or degenerative arthritis. It's simply things are finally, at this point, wearing out. But the point I was trying to make in reference to that is I don't have to worry about, well, I better not flex my elbow joint too many times today because I might get in trouble here, Of course, by the time you get to be my age, it's going to be degenerative arthritis in any event. But you understand what I'm saying? They're remarkably resilient. In addition to those kinds of arthritis, I mentioned gouty arthritis when you get urate-type crystals that get deposited in joints. Those are extremely painful situations and only happen in a very small percentage of the population. And then there's also rheumatoid arthritis, which has some immunological overtones. Let's take a look at an overhead that summarizes, not an overhead, I'm sorry. Let's go to a graphic that summarizes these forms of arthritis. Again, traumatic, degenerative, infectious, rheumatoid, gouty. There's probably some others. If you look arthritis up in a medical dictionary, you'll probably find 2 or 3 other minor types as well. But these are the major categories. What do they all have in common? Joints are inflamed. The thing that separates them one from another is the inciting etiology. The thing that's actually causing the inflammation is different from one type to another. Bryce.
Are any of those more common than the other ones, or are they pretty much evenly
Well,
distributed?
probably in young people, in general, traumatic arthritis is the most common type. I mean, just about all of us, sooner or later, sprain an ankle or twist a knee or suffer some kind of problem there. When you get beyond that, I don't know how the figures actually stack up. I know that gout is gouty arthritis, a very infrequent type of arthritis. There are some arthritides that are actually caused, we didn't put neoplasia up there, but you can have neoplasia or cancer of joint components, but usually the arthritis that's associated with that is of minor concern compared to getting the uncontrolled cell division under control. So, good question. I don't know the answer to it. Starling?
Are most arthritis cases in synovial, or are they all in synovial joints?
A lot of them, the bigger percentage of them are in synovial joints, but you can have arthritides that involve some of the other joint types as well. Can. I believe the credits are rolling, so I think they're done.
Okay, so like in my questions, Jenna, about